Bonjour, bienvenue, welcome to Massey College. My name is Nathalie Des Rosiers and I'm the principal of Massey College. It's my great pleasure to welcome you here. C'est un événement qui me fait grand plaisir parce que c'est l'occasion de célébrer aussi le bilinguisme de Massey College. I am very pleased to first acknowledge that Massey College is built on indigenous lands, the lands of the Huron-Wendat, the Haudenosaunee, and it is the treaty lands of the Mississaugas of the Credit. We want to honor our duty of stewardship toward this land and also the great privilege that we have to be here. Je veux reconnaître évidemment que nous sommes sur un territoire autochtone, le territoire des Huron-Wendat, des Haudenosaunee, et c'est un territoire couvert par le traité avec la communauté des Mississaugas de la rivière Credit. So this is a partnership between Massey College and the Royal Society of Canada. It is the 60th anniversary of Massey College this fall, and we decided to invite our partners to come and celebrate with us. So I am delighted that we created this little partnership. We will have a series of 4 substantive discussion about some major issues on which the Royal Society has exercised intellectual leadership and continues to do that. Alors, le but du partenariat est, entre autres, de promouvoir la recherche dans les 2 langues officielles du Canada, un engagement du public dans les grandes thématiques qui sont pertinentes pour l'avenir et du Québec et du Canada, et puis essayer de travailler dans un format bilingue, dans lequel les chercheurs sont encouragés, évidemment, de s'exprimer dans la langue de leur choix, mais aussi de permettre une certaine interaction. So today it's a bilingual event, and we have some translation that will appear on the screen so that they can follow it. And that's our first experiment with this, and maybe the next time we'll do it in Dutch, but I think we're trying it out, and I think we're hoping that indeed we can do more of that. This would make me happy, and it would be really a way to celebrate many of our students who are able to converse in French and do their research in French. Alors, I first want to introduce our first speaker, Barbara Nice, who is the incoming president of the Royal Society Academy of Social Science. Professor Nice is currently the John Lewis Payton Distinguished University Professor and Honorary Research Professor in the Department of Sociology at Memorial University. She is a member of the Order of Canada. She received a PhD in sociology from the University of Toronto in 1988. She's a former Trudeau Scholar Fellow, and she has an honorary doctorate from the University of Tromsø in Norway. And over the past 40 years, her research has focused broadly on interactions between work, environment, health, mobility, and communities in marine and coastal contexts. Barbara.
Thank you very much, Principal Des Rosiers. The Royal Society of Canada is very pleased to be back at Massey College following a series of successful events here prior to the pandemic. We're excited to re-establish this partnership, to see our overlapping communities come together once more, et de le faire dans le cadre d'une série d'événements visant à promouvoir la recherche au Canada dans nos 2 langues officielles. She's just introduced me, so I don't need to do that. La SRC est une seule et même organisation qui est composée de ces 3 académies constitutives et du collège de la SRC. Dans le cadre de cette série de dialogues de la SRC au collège Massey, chacun de ces 4 organes sera responsable de l'organisation d'un événement. The Academy of Social Sciences is very excited to be leading this first event in the series, featuring both speakers and indeed Dr. Des herself as members of the Academy. Today we will hear from Dr. Carole Estabrooks and Dr. Alain Noël as they discuss how we can work together to improve the health and well-being of the elderly. This topic is of strong personal interest to me, as I find myself at the age of 70 helping to care for two elderly parents who are 95, 8, and still living in the farmhouse where I grew up. The well-being of the elderly has been a key area of focus for the RSC, dating back to the establishment of the RSC Task Force on COVID-19 in the spring of 2020. Elle sera particulièrement mise en relief cet automne au cours d'un événement comprenant celui de ce soir, ainsi que d'un sommet de la recherche à Niagara Falls, suivi d'un colloque organisé par l'Université de Waterloo, qui auront lieu en novembre dans le cadre de l'événement célébrant l'excellence et l'engagement de la SRC. These events follow a series of policy briefing reports published by the RSC Task Force on COVID-19, which included Dr. Estabrooks, on post-pandemic healthcare in Canada, the future of long-term care, and investing in Canada's nursing workforce post-pandemic, amongst many other topics. An update to the Board on long-term care is expected in the coming months. Many of these COVID reports were published in Facets, Canada's first and only multidisciplinary open-access science journal. The Academy of Social Sciences is pleased to share that discussions are underway to integrate social science work more fully into the Facets journal, opening up an exciting opportunity for Social Science Canada doing multidisciplinary work to be published in an open-access space. Details of this opportunity are expected to be announced in the near future. Une fois de plus, au nom de la Société royale du Canada, je tiens à remercier Madame Des Rosiers et toute la communauté du Collège Massey de nous accueillir aujourd'hui. J'attends avec impatience le dialogue d'aujourd'hui.
So we're still working out the details here of how this is going to work out, but let's be patient. It's my great pleasure to invite Dr. Estabrooks. She is the scientific director of the Translating Research in Elder Care program, a professor of nursing at the faculty at the University of Alain. Her research focuses on quality of care, quality of life, quality of end of life for older adults living in long-term care centers, and on the long-term care workforce as well. Ensuring a quality of work life. I want to invite her to present her quickly her ideas, fabulous talk that I had a chance to read, so I'm looking forward to hearing you.
Great. Thank you very much. I'm so pleased that I get to use the lectern, so I'm in my comfort zone. Much more comfortable than sitting in a chair in front of you. I'll be brief. I want to talk about long-term care a little bit and about why you get there or how you might stay out of long-term care. It's on a lot of older adults' minds these days. Before COVID, about 50% of Americans who were surveyed in a survey that was done said they would rather die than go to a nursing home. That's pretty depressing. I'm going to guess if they were surveyed now after COVID, it would be higher, and probably Canadians would feel similarly. People are afraid to go to a long-term care home. I want to start by saying if you genuinely need it, and if the home, it is the right place to be, and if the home is providing you good quality care, if it has a good and healthy and resilient staff, if it has a work environment that's positive and enough resources and the staff are well trained, it can be a good place for you to live and die in your last years. But that's a lot of ifs. Most admissions to long-term care can be somewhat delayed and sometimes prevented, but not all of them. But I want to talk about the ones that can be delayed or can be prevented entirely, and because the things that cause you to end up in long-term care, many of them have early childhood interventions and midlife interventions. There are things that we do, even up into our 60s and 70s and 80s, that will help us be more resilient and able to stave off what seems like the inevitable. Health issues and some normal consequences of aging notwithstanding, I think the reason you land prematurely in a long-term care home is because as a society, we, as John Stuart Mill called it, to create a just society, one where people do not amass excessive or outrageous wealth until all have some basic level of wealth and ability to live decent lives. So how do you get into a nursing home? Well, the major drivers are older adults with frailty. That can be mitigated in large part. Older adults with dementia. Now, dementia is the scariest one. It's the major driver of admission to long-term care. It's a terminal disease. There is no effective prevention. There is no effective treatment. And you always die from it if something else doesn't get you. That's not so much what scares people. It's losing your mental faculties that scares people. But you can delay the onset of dementia quite considerably. There's lots of strong evidence out about how to do that now, and they're lifestyle things. They're not very exciting. Exercise, eating well, sleeping, community, and some other things I'll talk about. And when you get it early, the drugs that we do have can slow its progress for a while, but invariably it progresses. It doesn't ever not progress. And that population has a very hard time staying out of long-term care unless they have a lot of wealth. Ronald Reagan didn't go to a nursing home. Margaret Thatcher didn't go to a nursing home. Glenn Campbell didn't go to a nursing home. Rita Hayworth didn't go to a nursing home because they had the financial means to buy 24-hour in-care home. That's pretty expensive. I don't know what the exact cost would be. The last estimate I had was about between $250,000 and $350,000 a year. That's just a lot of disposable cash. Now, some people have it, like Ronald Reagan had it, but not everybody. The care there is highly complex when you do land in a nursing home, partly because we've compressed complexity and death. We don't take people into nursing homes as early as we used to because they don't need to be there. That's partly cost saving, of course, but it's partly because people are very clear they'd rather not live their last years in long-term care. But it's created a compression, and it's made the care really complex. It can be very gratifying care for a caregiver, but right now that's not really the state. The average person in a long-term care is probably 85. 2/3 of them are women. 2/3 of people with dementia are women. About 70 or 80% of people in a nursing home will have a dementia. They're almost all very frail. Most have multiple chronic diseases. You kind of pick these up as you go along through life. It's not that unusual. Diabetes, arthritis, cardiovascular disease. The people, however, who deliver the care, the most complex care in the healthcare system, are not the highest trained people. My goodness, no. 90% of them, that were about 90 or 95% of the care is given by on-regular personal support workers or care aides or orderlies. They're called different things in different provinces. They tend to be middle-aged and older. It's a highly racialized group. Well over half of the care aides are not white Canadians. The white Canadians are the minority in long-term care homes. And that wouldn't be so much of an issue if there weren't all the structural barriers and the impact of sex and race discrimination going on. They're not immune from it. They're mostly women, 95%. They're poorly remunerated. They often don't have benefits. They work multiple jobs. They send money home frequently. And they have little to no continuing education. They're at the bottom of a really rigid hierarchy. So that's who's looking after the most complex people in the system. We've got it upside down. But, and I'll say this, you'll see it in the new report coming out, there are lots of reasons that long-term care isn't the way it should be. We believe on the group that's doing the new report for the Royal Society that yes, there's age and sex discrimination, there's ageism and sexism, they're really rampant, but the core fundamental reason that it is the way it is in long-term care is because we do not consider old people to be fully human. They do not have the full rights and privileges of the Charter of Rights in Canada, of the International Charter of Rights and Freedoms, of the UN Charter of Rights and Freedoms, or anybody else's Charter of Rights and Freedoms. Because if they did, we wouldn't restrain them against their will. We wouldn't have put them in isolation, the equivalent of solitary confinement for months on end during COVID, and a raft of other things. That's a social issue. That's not the problem of the healthcare workers. Healthcare workers are just living out what society is telling them to do. We have a big job in front of us if we're going to figure out that old people have the same value with their lives lived that little kids do with their lives in front of them. Because you didn't see little children put in solitary confinement during COVID. That's the core issue. It's hard to get at, and we can't fix it for ourselves all at once, but you can do some things to make it more likely you won't get there before you need to, or not get there at all. You can have a catastrophic event, of course, like a massive stroke, and then you lose all agency no matter how many clever plans you've made to stay out of long-term care sometimes. Even if you're one of those people who'd rather die than go to a nursing home and you've made plans to commit suicide so you won't have to go, it's kind of an extreme plan, but I know lots of nurses who've made that plan. If you have a stroke, you lose your agency. So it's a complex issue. It's not easy to say, I'm going to take control of this and manage it myself. So, I've talked about why you get there. Let me talk about a few other things than the health reasons. You have to be able to take care of yourself to not go to a long-term care home. Or you have to have family or friends who are willing to help you or take care of you. You have to have a home. You have to be able to afford to maintain your home or pay your rent, which is increasingly difficult. But a lot of people don't have family, especially women as they age. A lot of people have family, but they're not close, not willing to come closer. They can't afford in-home care, or they have no home. The homeless rate for older adults doubled in the last decade in Toronto, and that's probably signals what's going on in the rest of the country. But things you can do, things you can control, you can stay able to get up and down off the toilet. That sounds kind of boring, but if you can't get up and down off the toilet, it's really hard to be independent. So don't buy for high ones. Maybe not the super low ones, they're really tough as you get older, but the medium ones allow you to continue to use your muscles. Keep going up and down stairs. Everybody wants me to move to a condo with no stairs, but I keep thinking maybe I should keep using the stairs as long as I can because it's good for functional mobility. Walk if you can, get out if you can. You have to be able to be cognitively enough so you don't burn the house down or leave your doors open or let strangers in and that kind of thing. And that's not easy. It's impossible at certain stages of dementia. You have to be able to maintain some degree of social interaction and connection with other human beings. We know now it's a really strong predictor of doing well as you age. You have to be able to get out and about a little bit. Yeah, you can call Save-On or have your food delivered, but if you only ever stay in your house, you will develop a really significant social isolation and you will deteriorate more rapidly cognitively. So the key message is you have to prevent or delay dementia or frailty. You have to stay connected. You have to eat well enough. You don't have to eat gourmet, just like soup and sandwiches. Just eat well enough. You have to exercise. You don't have to run marathons. All that stuff you see about 5-year-old women that are running 100-meter dashes, that's the super agers. They're out here in the tails. They're just like a tiny, like maybe 0.1% of the population. That's not reality. You just have to stay active enough and try not to fall down because falls get quite serious as you get older, especially for women, and you have more injuries. We know now that not sleeping well has an impact on poor aging. So you're not going to sleep like you did as an 18-year-old ever again, but try and sleep well enough. You have to have access to primary care, increasingly difficult, but we have nurse practitioners now and they can provide a lot of primary care. And if you need it, you need access to mental health care. And that's really a significant problem in Canada. So I'm going to end by making a special note of something that happens early in people's lives that causes them to age very prematurely and end up prematurely in all kinds of difficult situations. So COVID made it slightly, but just slightly less stigmatizing to talk about psychological trauma. Mostly we don't like to talk about trauma, it's not a nice word. So I'm going to use that. We all know about the big things that cause broad traumas. We all know about the Holocaust. We all know about residential schools. We know about war and war crimes. We know about major disasters, and we've had our share of them lately. We know that many people work in fields where they're overexposed. First responders, soldiers, nurses, physicians, especially during COVID. Or we know that many people experience single event adult trauma, sexual assault and near drowning. They spend 10 days in ICU. That can be very severely traumatizing. We know, but we really prefer not to talk about it in polite company, that large numbers of children outside of the residential school and similar settings, which is bad enough, experience severe childhood trauma from assault, rape, neglect, and a host of other things. And we know that leading trauma psychiatrists in the U.S. identify childhood trauma as the #1 public health emergency in the United States because it hurts your brain. It causes injury to your brain. It's repairable, but unrepaired, certain coping mechanisms kick in and they make you sick, and they cause a host of other problems. So there's a thing called your HPA axis that's really important for regulation. It goes catchy. You start cranking out cortisol, and it's like you've got your foot on the gas and you can't get it off, and you develop all kinds of inflammation. Inflammation leads to diabetes and heart disease and blah, 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 blah. You have trouble forming relationships. But if you have a host of other problems. People with addiction, Gabor Mate in Vancouver argues that there is no addiction without a history of childhood trauma. So a lot of our addiction and opioid problems come from untreated childhood traumatic experiences. And it's intergenerational. It's a gift that goes on giving. We know that if you score 6 or more on the 10-point childhood adverse event scale, that you will live an average of 20 years less than somebody with a score of 0. You will live with chronic disease, chronic pain, misdiagnosed mental health disorders, frequently with substance and addiction issues, but not everybody does this. The world is full of people out there on the street walking around with quite severe PTSD. But if your frontal cortex is intact, if you've found a good relationship, if you found mastery in your work, professional success, all that helps mitigate. And as long as you've got that cortex, you can manage it. But then you get dementia, and you end up in a nursing home. And this comes apart first. And so you start losing the ability to manage all the things that are dysregulated. It comes out as really severe behavior problems. You get misdiagnosed, you get put on medication, you get chemically and physically restrained. If you're put on a behavioral unit, and if it's really severe, in some cases you're sent to a psychiatric hospital to live the rest of your life. They won't take a trauma history because we don't talk about it in Plate Company. There may not be anybody to take it from. So you can have a really bad time in a long-term care home if this isn't treated. So how do we fix this? We create the social structures that allow people to talk about it, that give people access to proper care. And it's only been since 2014 that we really have understood that the impact is on the brain and not in your mind. It's not a personality disorder. It's an injury that's causing certain things. And you've got locked into a pattern that's causing these things to just keep going. So if we would intervene early with kids, we would prevent miserable aging. If we intervene with young adults, or if we intervene with middle-aged adults, we'd prevent a lot of suffering. But even if we mess that all up, if we created trauma-informed care environments that don't re-traumatize the older adult or the staff, because if 60 or 70% are coming from other countries, there's a province in this country that's going to refugee camps to recruit carries. I don't know who thought that was a good idea. You know, because you're bringing now the pre-traumatized in to work with a population. We don't know what the percentage of people in nursing homes are with PTSD, active PTSD. The numbers say 9 to 35 or 40, but the research is really bad in this area right now. But we can create environments that are safe, where the staff aren't hurt again, where the residents aren't hurt again, where you can still have a good quality of life. But to do, you have to have a viable workforce that's treated decently, that's paid decently. And because as Pat Armstrong, my colleague at York, would say, the conditions of work are the conditions of care. So I'm going to stop now because I could go on. I can feel myself getting wound up. There's a lot. I want to end by saying there's a lot we can do, even if we screw it all up all through your life. There's still a lot we can do if we would pay attention in nursing homes to proper care environments and resilient and healthy staff. Thanks a lot.
Well, Thank you so much, Dr. Estabrooks. In your paper, when you say, is the highly vulnerable who look after the highly vulnerable, it's such a phrase that kind of stops us referring and understanding what's going on. And so I think we'll have a chance to talk about what's the impact of trauma and how do we go from there. Because now we're going to talk about the more mega. How do we solve it? Je suis bien contente d'accueillir Alain Noël. Alain Noël is a professor of political science at l'Université de Montréal. He works on social policy in a comparative perspective, as well on federalism and Canadian and Quebec politics. Il a publié de nombreux livres et de journaux scientifiques, including the American Political Science Review, the Canadian Journal of Political Science, Comparative Political Studies. His latest book is entitled Utopie provisoire, essai de politique sociale, qui a été publié en 2019. I'm really happy to have you here with us. Merci beaucoup, Alain, d'avoir fait le trajet jusqu'ici.
Merci beaucoup pour l'invitation. Merci aux gens de la Société royale d'avoir organisé tout ça. Je vais commencer en reprenant l'objectif de la décennie des Nations unies. Bon, je vais parler en français, je vais essayer de parler pas trop rapidement. J'ai regardé un peu la machine à travailler, j'ai quand même des doutes, mais on va voir. Donc, l'objectif...
Artificielle. On a encore du travail à faire.
OK. Donc, l'objectif de la décennie des Nations unies... L'objectif de la décennie des Nations unies pour le vieillissement en bonne santé, 2021-2030, je cite, « de réduire les inégalités sanitaires et d'améliorer la vie des personnes âgées et de leurs familles et de leur communauté par une action collective. » Comme politologue, comme l'a mentionné Nathalie, j'ai pas vraiment d'expertise sur les soins de santé, le vieillissement ou même le fonctionnement des communautés. Je travaille sur les politiques sociales, donc alors que Carole est plus sur le terrain des personnes, je passe en avion puis je regarde, je compare les pays. Et donc, les constats que je vais faire aujourd'hui sont tirés des travaux que j'ai faits souvent avec Olivier Jacques, un jeune collègue, avec qui j'ai travaillé beaucoup dans les 2-3 dernières années. Je vais vous soumettre 3 idées. Je les présente tout de suite pendant l'attention, puis après ça, je vais développer. La première idée, dans l'objectif de la décennie des Nations unies, l'accent est mis sur les inégalités sanitaires, donc les inégalités de santé entre les personnes. La première idée que je veux vous soumettre, c'est que tout en reconnaissant la réalité et l'importance des inégalités sociales de santé, il faut se garder d'en faire l'alpha et l'oméga de nos stratégies sanitaires. Il faut prendre un certain recul par rapport à cet enjeu des inégalités sociales de santé. Deuxième idée, et là, c'est des idées qui ne vont pas de soi nécessairement, là. Deuxième idée, ce sont moins les inégalités et la redistribution qui déterminent la santé des populations que les ressources concrètes offertes par l'État-providence, la protection sociale, les services sociaux, qui contribuent à démarchandiser les rapports sociaux. Je vais expliquer ce que ça veut dire, mais gardez l'idée qu'il ne suffit pas de réduire les inégalités par la redistribution. Troisième idée, dans les circonstances, la meilleure stratégie consiste à miser sur l'universalité des programmes sociaux, des transferts et des services sociaux, services publics, ou peut-être à favoriser un universalisme ciblé, c'est-à-dire une forme d'universalité qui se complémente avec des mesures plus sélectives. Donc, commençons par la première idée, les inégalités sociales de santé. On sait que dans une même ville, à Montréal par exemple, les gens qui vivent, bon, dans le cas de Montréal, à Hochelaga-Maisonneuve, ont une espérance de vie d'à peu près 11 ans moindre que ceux qui vivent dans les quartiers plus riches de la ville. Donc, clairement, il y a des inégalités sociales de santé et c'est un fait qui est reconnu. Les inégalités sociales sont bien réelles et il ne s'agit pas simplement de pauvreté. Ce n'est pas seulement les gens qui sont pauvres qui sont touchés par les inégalités sociales de santé. Il y a ce que les chercheurs en santé publique appellent un gradient social. Les gens sont plus enclins au fur et à mesure que leurs revenus augmentent. Donc, les gens qui sont au milieu de l'échelle des revenus sont au milieu de l'échelle de la santé à peu près en termes de longévité et de qualité de vie. Donc, si on fait ce constat que les inégalités ont un lien avec la santé, on peut conclure, comme le faisait un rapport international, que la pauvreté tue à grande échelle. Donc, réduire la pauvreté, réduire les inégalités, ça semble aller de soi. Or, ce n'est pas si simple que ça. On constate que dans les pays nordiques, qui sont les plus égalitaires à peu près dans les démocraties, il y a toujours des inégalités sociales de santé et elles sont relativement importantes. C'est ce qu'on appelle le puzzle de la santé publique. Comment ça se fait que des pays qui redistribuent davantage n'ont pas des meilleurs résultats par rapport aux inégalités sociales de santé? Et l'explication, en bref, c'est que quand on crée des programmes sociaux, quand on des transferts sociaux qu'on redistribue, on contribue à améliorer la santé des gens, mais la santé s'améliore pas juste en bas de l'échelle, elle s'améliore en haut de l'échelle aussi. Tout l'escalier du gradient social monte, ce qui fait que les gens plus pauvres deviennent plus en santé qu'ils l'étaient, mais les gens plus riches profitent également, puis même, c'est toujours presque le cas dans toutes les politiques publiques, les plus riches profitent plus des avantages sociaux que les plus pauvres. On parle de l'effet Matthieu pour décrire en Bible, on donnera aux riches et on oubliera les pauvres, pour décrire ce phénomène-là. Et donc, ça signifie que si on adopte des politiques de santé publique, tout le monde monte. Il y a un chercheur suédois, Ole Lundberg, qui disait finalement, c'est quand même un succès de santé publique si tout le monde est plus en santé, même s'il y a des gens qui sont moins en santé que d'autres. Et on peut voir la même chose dans des données que j'ai regardées plus récentes pour le Québec. Au Québec, la mortalité prématurée, c'est-à-dire mourir avant 75 ans, a diminué significativement entre 1989 et 2013, et ce, pour toutes les catégories de la population, faisant du Québec une des provinces le plus faible taux de mortalité prématurée. Donc, ça s'est amélioré, mais le progrès a été encore plus marqué parmi les plus fortunés, ce qui fait que, tout en améliorant la santé de tout le monde, on a empiré les inégalités sociales de santé. Mais est-ce qu'il faut y voir un échec? Pas nécessairement. Si tout le monde vit plus longtemps, c'est quand même un succès. Donc, il faut garder une certaine prudence quand on met l'accent sur les inégalités sociales de santé. Ça ne peut pas être le seul guide pour nos interventions. Et même Julia Lynch, qui est une politologue américaine, dans un livre récent, suggère que l'accent mis sur les inégalités sociales de santé peut nous faire oublier l'importance de grands programmes sociaux universels, de la redistribution générale, d'une stratégie qui vise l'ensemble de la population. Donc ça, c'est mon premier point. Restons prudents face à la question des inégalités sociales de santé. Qu'est-ce qu'on fait alors? Si il ne suffit pas de redistribuer, comment on améliore la situation? Dans une étude parue en 2022, donc c'est plus dans la revue PLOS ONE que j'ai réalisée avec Olivier Jacques, que j'ai mentionné tout à l'heure, on a regardé les déterminants de la longévité dans 21 pays de l'OCDE sur plusieurs années, de 1971 à 2010. Et ce qu'on trouve, et ce n'est pas entièrement original parce que ça confirme ce qu'on savait un peu dans la littérature, ce qu'on trouve, c'est que la redistribution et l'égalité n'est pas associée à la longévité. Et donc, il ne suffit pas de redistribuer, ça renforce le point sur les inégalités sociales de santé. Qu'est-ce qui marche, cependant? Qu'est-ce qui améliore la santé des populations? C'est la générosité de l'État-providence. Donc, des bons services publics, universels idéalement, protègent les personnes contre les risques sociaux, contre l'insécurité, et notamment, ça fait partie des résultats qu'on a dans notre étude, sont particulièrement efficaces quand le marché crée une polarisation des revenus. L'intervention de l'État vient corriger cette situation. Donc, il faut miser sur l'État-providence pas nécessairement comme machine à redistribuer, mais comme machine à offrir des services publics. Loin de l'idée de renoncer à la redistribution, il faut voir la redistribution et l'égalité comme un bien en soi, donc un objectif nécessaire dans une société démocratique et capitaliste. On ne peut pas faire l'économie de la redistribution, mais ce n'est pas la clé pour promouvoir la santé. Donc, service public généreux. Troisième idée, et la troisième et dernière idée, idéalement, ces programmes sociaux seront universels. Universels, c'est-à-dire qu'ils sont offerts à tous en fonction de la simple citoyenneté ou résidence et non pas en fonction de contributions passées. Il y a des très bons arguments qui justifient une stratégie universaliste. L'argument classique, ou relativement, celui qui a été le dominant dans les 20-30 dernières années, c'est un argument qui avait été développé par les chercheurs suédois Walter Korpi et Joachim Palme, qui montrait que quand on donne à tous, on redistribue davantage que quand on cible les pauvres. Il fallait faire des programmes universels. Les conclusions de Korpi et Palme ont été critiquées dans les 10 dernières années, mais dans les travaux que j'ai faits, encore une fois avec Olivier Jacques, publiés dans le Journal of European Social Policy, on a repris la démarche de Korpi et Palme, on a adopté une meilleure mesure de l'universalité et on est arrivé à la conclusion qu'effectivement, l'universalité fonctionne encore. Pourquoi l'universalité fonctionne? Parce que, d'une part, ça favorise la réduction de la pauvreté et la redistribution, mais je vous ai dit que ce n'est pas suffisant pour la santé, mais c'est que l'universalité favorise aussi, et ça c'était l'argument clé de Walter Korpi, quand on s'installe sur le mode de l'universalité, les classes moyennes sont plus enclines à contribuer leurs impôts et leurs taxes à l'État-providence, et donc on investit davantage dans la protection sociale, et ça fait un effet significatif, parce qu'on a vu, dans l'idée 2, que les services publics sont essentiels pour maintenir la santé des populations. Donc, conclusion, gardons une certaine méfiance face à la tendance à tout miser sur la lutte contre les sociales de santé, tout en reconnaissant l'importance du problème. Établons sur un État-providence généreux, universaliste et ciblé en complément. Il faut se soucier toujours de la pauvreté et favoriser la redistribution, mais la santé et le bien-être sont d'abord et avant tout l'affaire de toute la société. Merci beaucoup.
Merci beaucoup, professeur Noël. Je pense que c'était un bon panel d'avoir au début when we heard you, Carole, I think we were all getting pretty scared. And that was the point. Et puis là, au moins, on a un aspect, une taille de solution ou un peu un plan de travail. And so I'm going to do for this part, I'm going to ask a few questions to each of you. And then we'll open up to the group. So my first question, Carole, is the baby boomers have had the ability to manage well in terms of politics, in terms of getting heard, because of their demographic weight. How come it is now an issue for the baby boomers? How come it's not getting solved?
Well, that's a big question. Not all the boomers participate equally in what you've talked about. When I go and talk to groups that would have the early and mid boomers, because the early boomers are about 75 now, give or take, they're not talking about the sorts of principles that we've just heard about. Their questions are very clear. How much will it cost me to stay out of long-term care? So there's a group of boomers with significant wealth, but there are just as many without significant wealth. I don't think the group with wealth are angry enough and worried enough. That's my own personal view. And I think the other group aren't able to. They don't have access, they don't know how to. They don't feel good. They're worried about where their next meal is going to come from. There's a new report coming out, I was told yesterday, that says that most, I can't remember the exact percentage, but a significant proportion of Canadians will retire without a pension and with $2,800 in their savings account. A significant proportion. That's probably not the people in this room, but so the people at the tables aren't those people. Mm-hmm. It is the people who've amassed considerable, what we consider considerable wealth. If you're in that group, you probably don't consider considerable wealth. So there's not an easy answer to that. I think the boomers have had the same condition the whole country's had. Like, I don't think they intended to age. Mm-hmm. I don't know how they thought they'd avoid that. Right. Like, it's hard to imagine yourself old. Even when it's happened to you, you're going around all the time thinking, how did this happen? And it's hard because you have to look at your own mortality, and you have to admit you might need certain things. And it's just not very much fun to lobby for those. You know, really, I mean, I think it's that much at a fundamental human level. It's right there. There are all kinds of other reasons. The people in politics aren't worried about going to a nursing home. Yeah. I mean, most people in politics today, many of them have significant wealth accumulation, leading the G7 and the G20 countries. And if they haven't had it before, they make money on having been senior politicians. And that isn't, it's not that they don't care. I don't think it dawns on them. Mm-hmm. And yes, they get policy advice and they get lobbied and they get this and they get that, but I don't think the lobby for a more protected society for older adults has been very strong, because we still owe it. Well, oh my God, you know, they only retired with $2,800. What did they do wrong? Mm-hmm.
So we individualize it.
Yeah, it's not an individual problem, it's a social problem. Mm-hmm. There are individual things we can do, but you never can fight the social things individually or one by one. Mm-hmm. So I think that blaming people who don't have the same advantages that we have is not, it's just not helpful, and it's just not actually true. That everybody's to blame. That's kind of like blaming people who come into the hospital for lung cancer because they smoked for 15 years. Well, I guess you could, but let's add up all the things we could blame people for, you know.
There's a colleague here that says, in a capitalist society, no greater sin than not looking after yourself, than not being able to buy things for yourself. You know, c'est a fundamental flaw if you're not. Je vais aller vers Alain là, un petit peu. L'universalisme des programmes. Le dernier qu'on a eu, on dirait peut-être les garderies. Comme si on pense que c'est... Alors, quel programme... où est-ce que vous commenceriez? C'est quel programme universel metteriez-vous de l'avant tout de suite pour répondre un peu là, aux enjeux que Carole a développés?
Je retiens la question, mais avant je voudrais intervenir sur la question précédente.
Oui.
Juste pour garder que dans l'État-providence contemporain, et c'est le cas au Canada également, les deux plus gros postes de dépenses concernent les personnes âgées en priorité. C'est les pensions et la santé, ou plutôt la santé et les pensions. Au Canada, surtout, on ne dépense pas beaucoup sur les pensions en tant que public. Mais ça veut dire que les personnes âgées reçoivent déjà beaucoup. Et les jeunes sont en droit de se demander si on n'en fait pas trop. Donc, il y a quand même une partie importante. Là où on a été négligent, je pense qu'on l'a vu dans la pandémie, c'est sur les soins aux personnes non autonomes. Là, c'est vraiment un volet des politiques publiques qui est négligé dans tous les pays. Hein. On a vu des désastres un peu partout. Donc, en tout cas, ça, c'est pour la question des générations. La question de l'universalité, ça peut s'appliquer à différents programmes ou services. Ce qu'on fait assez mal, je dirais, au Canada notamment, là, on instaure des programmes prétendument universels, mais qui ne sont pas vraiment. L'exemple des services de garde, c'est ça finalement, c'est que on crée un programme pour tous, mais on limite le nombre de places. On fait ça dans la santé aussi. Finalement, l'accès aux services est difficile. Donc, la capacité de... Je pense qu'avant de créer de nouveaux programmes, il faudrait s'assurer qu'on livre la marchandise pour les programmes qui existent déjà, ce qui est déjà une grosse commande.
Et est-ce que, dans cette veine-là, vous diriez que ça serait une amélioration des services de santé? Et qu'est-ce que vous dites de l'assurance médicaments, par exemple? Est-ce que c'est nécessaire d'avoir l'assurance médicaments pour vraiment répondre aux problèmes de santé, ou bien on est mieux de se préoccuper un peu de un bon service, l'accès à un médecin de famille? Est-ce que c'est là où vous essayez?
Moi, je pense que l'assurance médicaments, c'est incontournable.
Okay.
Ça fait partie, justement, des limites de l'université. On a des soins de santé qui sont gratuits, universels, et tout ça. Mais si tu as besoin de médicaments, tu dois payer ou avoir des assurances privées. Et donc là, il y a comme un volet de l'intervention qui nous échappe.
So, Carole, if I come back to you, the question about what would you ask as a priority to a provincial government? Like, what would be your first ask?
It would be about addressing incomes. So if you're a single pensioner and all you've got OAS and the guaranteed income supplement, you're living on about $21,000 a year. Now, I don't know how many people in this room could live on $21,000 a year. So that's what I would do. That's non-health related. It's very health related. I would lift pensions right across whatever board we have. And I know I hear the hue and cry about, oh, the boomers, oh, now they're at it again. They're going to take all our pension money. There won't be anything left there. There are tax systems across the world that we could look to for more suitable solutions. So I think we have a lot of work, we get a lot of room, and this is a wealthy country. This is a high-income country that's very desirable to live in. We could lift public pensions. Then I would, well, there's lots of other things that Alain would be more equipped to answer than I would, but I think
he's going to get his chance.
It's worrisome when you have people who like blue-collar laborers don't, you know, if you grew up with parents who were working poor, you know what it's like. It's no time to think about all the fancy things and travels you might do when you retire. You're picking potatoes in the field to put clothes on the back of your kids for winter, or whatever they do now. That's what they did when I was little, but they do other things. But it's a great day to day. It's not like they're sitting back, you know, watching, you know, stars on ice instead of going out and hustling. So we have a lot of blue-collar workers in this country, and some of them are very well paid. But we have a lot of poorly paid work in this country, part-time work, casual work, seasonal work.
Alain, l'approche à un gouvernement provincial, après ça on ira au fédéral après, là, mais la première demande.
Je ne le diviserai pas par provincial, là, mais je suis d'accord avec Carole que les pensions au Canada protègent mal le revenu. Elles maintiennent les gens un peu au-dessus du seuil de la pauvreté, mais contrairement à ce qu'on pense souvent, on ne dépense pas beaucoup pour les retraites, pour les pensions au Canada, donc il y a de la place pour faire mieux. Un autre domaine où, puis là aussi c'est peut-être le gouvernement qui devrait réfléchir, mais un domaine où on ne fait pas très bien, c'est toute la protection du revenu pour les personnes qui vivent avec un handicap.
Oui.
C'est une situation qui est... c'est un mélange de programmes qui s'appliquent. On passe de... Ça dépend... Si tu es handicapé parce que tu as eu un accident d'auto, tu n'as pas la même protection que si tu as eu un travail, que si tu es né avec. Donc, là, il y a mieux, on peut faire mieux sur ces questions-là. Et on est très... là, c'est les provinces, là, mais on fait très mal aussi pour l'aide sociale. On est parmi les pays les moins généreux. Il y a les États-Unis qui nous suivent, mais autrement, on maintient les gens très loin sous le seuil de la pauvreté.
Elle a dit, l'approche comparative est très stimulante et d'une certaine façon, ce sont des détails ou des comparaisons qu'on devrait faire plus souvent. Est-ce qu'on est mal servi parce qu'il y a peu d'intérêt sur ce genre de comparaison, tu sais, de faire sur l'aide sociale puis de démontrer que, de fait, au Canada, on est beaucoup moins généreux qu'ailleurs? Comment ça se fait qu'on n'est pas capable de se préoccuper de ces questions-là et d'y répondre? Comme politicologue, là.
Ouais, c'est un peu mon pain et mon beurre, donc j'ai l'impression qu'on le fait, qu'on s'en occupe beaucoup, mais effectivement, au Canada, on a tendance à se comparer avec les États-Unis, puis on se dit, ah, bon, on est bon. Et c'est avec l'Europe qu'on doit se comparer. Et là, ça nous permet de prendre un peu mieux la mesure de où on est, de ce qu'on fait, de ce qu'on réussit moins bien. Ça ne veut pas dire qu'on échoue sur tout, mais je pense que c'est important, effectivement, de comparer. Et c'est souvent difficile, en fait, de comparer, d'autant plus que le Canada est une fédération, et là, c'est qui est responsable, comment les programmes s'organisent, etc. Je travaille dans le cadre d'une collaboration entre l'Université de Montréal, l'Université de Bruxelles et l'Université de Genève. On a comme ils appellent ça le G3, un groupe de travail sur la protection sociale dans les fédérations. Donc, c'est fantastique parce que on voit comment les Belges qui ont leurs propres difficultés, les Belges et les Suisses s'organisent et permettent justement de mieux se comprendre mutuellement.
I want to finish with one question for you, Carole, on trauma. A little bit, I was struck in the statistics about trauma suffered as a child diminishes by 20 years. Your ability to live sounded a fairly astonishing and scary result, but one that you would want to respond. And I think many of the things you mentioned were about identifying trauma, supporting access to help. If I understood you correctly, you were saying that this is kind of new research, or it's relatively new in making that link. Is that, can you elaborate a little bit on that?
The neuroscience is about 30 years old, but it wasn't until an American psychiatrist, Vanderkolk, published an accessible book to the reader, The Body Keeps a Score, where a normal person could read it and say, oh my gosh, I feel this way, or I understand this phenomena as an injury to various parts of the brain, and it can be fixed, it can be repaired. But it doesn't get better on its own, and it doesn't get repaired by 28 years of psychoanalysis or most medication. A lot of people with severe, especially women-resistant depression, the underlying problem is trauma. A lot of people get like this hideous diagnosis of borderline personality disorder, and that's now understood by knowledgeable people to probably be related to trauma. So, and I've lost my train of thought, but I did want to go back and say that, so yes, the science is relatively new, but it's been popularized since that book's come out. It's been on the New York Times bestseller for nonfiction since 2014. So I think people are reading it and saying, oh, of course, it's also resulted in and not to be disparaging of psychologists, but every psychologist in the country's got to shingle out his idea with trauma. But it actually takes some specialized knowledge, not complicated to get, but about, so after 9/11, for example, it was all political, right? They got together with the insurance companies to see what would we cover for effective treatments for trauma, because they're all going to be traumatized. They watched people jump buildings, the towers fell, it was hideous. So they decided in their infinite wisdom that cognitive behavioral therapy and psychoanalysis, because it was Manhattan, would be covered. So they went back 3 years later, and they talked to the people who were there, who were still living in New York, and had been intimately involved in one way or another. And they said, did you use these services? Almost no one had used either one, had been to a doctor or a psychologist. And they said, well, what did you do? And they did what, if you understand how it works on the brain, they were naturally led to do things in community, in connection, in groups, with family, with quilting clubs, with book clubs, with just normal, regular stuff to put them in connection with people. and so they did it, they figured it out all by, it's not the only, but many of them with, that would be considered a single incident adult event, and that's easier to manage than a childhood one that's been persistent over time. But so that the cures and the fixes and the repairs aren't, they don't have to take 20 years on it. And who could afford that anyway? The colleges are charging $200 an hour. It's pricey help. And you may need some of that at some point, but a lot of the solution about how we build healthy, resilient communities, that would take you back, if you're familiar with it, to indigenous principles and all sorts of other things. But and we see it in the workplace too. We ask the PSWs and carries, how did you manage during COVID? They didn't go to their employee assistance programs or a psychiatrist or a psychologist and all that fancy stuff. They said, my team, my family, my faith. Those are all collective supportive things that really help to mitigate the effects, especially of adult onset trauma. And there's a lot, that's not the only thing you have to do, but that's a key component, and that's about a civil society, a caring society, collective society.
And people willing to support each other. So let's open up to the questions from the floor. If I, yes, Linda, oui. Oui, vous pouvez certainement parler en français, puis vous pouvez avoir accès au micro.
Bien, tout d'abord, merci beaucoup de vos présentations que j'ai trouvées absolument faciles. Ben, vous pouvez lire là. Est-ce que vous m'entendez?
Oui.
Oui, OK. Alors, félicitations, vos présentations étaient vraiment très inspirantes et j'essayais de faire le lien entre les deux présentations. Ce que j'ai trouvé intéressant dans la première présentation, c'est que ça nous amène à réfléchir sur les parcours de vie et l'incidence des parcours de vie, je ne sais pas comment on dit ça en anglais, mais là j'ai hâte de le savoir, l'incidence des parcours de vie sur la santé, et sur le vieillissement, etc. Mais en termes de politique publique, c'est là où j'ai un gros interrogation parce qu'on met beaucoup l'accent dans les provinces sur les politiques de santé. On parle toujours des politiques de santé, mais ce que je comprends, Alain, de ton intervention, c'est que il faudrait que ces politiques-là interagissent mieux avec d'autres types de politiques qui peuvent avoir une incidence assez importante sur le parcours de vie et les inégalités en santé. Et en fait, ce sont ces autres types d'interventions qui permettraient peut-être de mieux mesurer la réduction des inégalités en santé. Mais là, je ne sais pas si tu as des données sur les types de politiques, ces autres types de politiques. Tu as parlé de l'aide sociale, mais les politiques de lutte contre la violence faite aux femmes, les politiques pour favoriser le développement de centres communautaires, politiques qui cherchent à renforcer le lien social. Est-ce que ça, tu as des données là-dessus où on peut voir comment ça contribue à réduire les inégalités? Et deuxièmement, est-ce que tu sais, toi, ben je pense que j'ai la réponse, là, mais est-ce que tu sais, toi, si quand on réfléchit aux politiques, on voit ces interactions qu'il y a entre les politiques et que si on pense une politique de santé, on cherche à voir comment ça peut interagir avec d'autres types de politiques. Est-ce que vous avez ça dans vos travaux? Merci.
Ça me ramène il y a quelques années, j'ai participé à une conférence à Anvers, en Belgique, qui réunissait des gens qui étaient dans un gros projet financé par l'Union européenne sur la cohésion sociale et les politiques sociales. Et puis, il y avait dans les chercheurs qui étaient associés à ce projet-là, il y avait deux groupes qui se parlaient avec difficulté. Il y avait un groupe de chercheurs qui était plus... disons, liés à la sociologie de travail social, organisation communautaire, qui étudiaient des interventions communautaires, des politiques sur le terrain, puis des recherches qualitatives pour voir un peu qu'est-ce qui aide pas, etc. Puis de l'autre côté, il y avait les gens qui étaient plus économie politique, qui faisaient des analyses quantitative sur les dépenses, les impôts, les programmes. Moi, je m'associais plus à ce groupe-là. Mais ce qui était remarquable, c'est que ces gens-là ne se parlaient très peu, en dépit de l'appartenance à un même réseau de recherche. Et je dirais même qu'il y avait un peu de mépris mutuel, probablement, d'un côté et de l'autre. Et donc, dans le fond, on a de la difficulté, beaucoup des interventions dont tu parles, des mesures pour la violence faite aux femmes ou de l'organisation communautaire, c'est très difficile à mesurer. Et les gens qui mesurent disent, bon, ben, il n'y a rien à faire avec ça, on ne sait pas. Tu sais. Ceux qui veulent étudier ça font des recherches qualitatives qu'il est difficile de rattacher à des conclusions qu'on peut tirer en regardant les dépenses et tout ça. Donc, ça demeure deux univers de réflexion complémentaires, mais qui ne se parlent pas beaucoup.
Ah, c'est un beau, that's a good Massey project there. And you have a question? Yes. Yeah. I'll take a few of our questions since our time is coming. So take one question and then you, and then maybe I'll ask the panel to answer. Yes.
I have to preamble that I am not an academic. I am sort of a pseudo-academic. My current field is corporate governance. And I would like to challenge all of you here. Mm-hmm. In my view, and I'm doing some research now, I began both in the for-profit and not-for-profit, long-term care facility and healthcare facility. How many doctors are on the board of directors and the governors? How many nurses are on the board of nurses? And how many residents are on the board of directors or the board of governors? Currently, in my experience, and I have plenty, including I was governor of a hospital, you donate, you get on the board. You are a real estate developer, you get on the board. You are a supplier of major equipment, you are on the board. But the professionals who ought to get into the governance issue are excluded. I would be very interested in whether you concur with me or not.
Absolutely. It's exactly what happens. We could learn a lot about self-governance from our Indigenous communities. The fact that we have boards making really important decisions, I mean, they're making resource decisions, and those have serious implications. Without people, older people, not rich older people who are donors, but people who live in these facilities, their families, and their caregivers, is outrageous. But it's based on what I know, it's standard practice. Mm-hmm. I mean, a home is doing good if it, well, in our province, they had to mandate family councils. But that's not a governing board, that's a board that, from my observations, the home manages, so they don't create too much kerfuffle. And some homes...
There's a difference between managing and governing.
Absolutely, yeah.
And, is the governing is, I am very concerned with.
Oui, une autre question? Yes, yeah.
Thank you. I wanted to thank you, the speakers, very much for frank and clear and kind of depressing talks. It seems like everybody's out to get us, you know. I'm not sure when the elderly starts and whether you have a metric around that or whether that is the sort of question of not years, but, you know, frail and so on and so forth. And it'd be interesting to hear that. But it does seem like everybody's out to get us. And the sort of further I get, and I'm in my 70s, you know, I think, all right, everybody wants suicide, which is really cheap. Like euthanasia is really kind of push, like, wow, why don't you think about this? And why aren't elder care kind of residences and so forth, why aren't they part of the medical system? Like, why universal care stopped at some point? Why is universal care not extended to the elderly so that people caring for people who are old and need it, you know, are paid properly and the care is regulated? There's a lot of questions there. Sorry.
I think fundamentally I'll go back to the fact that we don't consider them fully human and fully worthy of our resources and our time. And that's a big issue. I mean, I will say, and then I'll correct myself, that we don't treat them as well as we do children, but it's not just about old and young, because we throw a lot of children out like human refuse if they don't fit what we consider a proper child image to be. So kids from troubled homes, kids with parents who've had addiction, kids who have severe behavior problems. I have a physician colleague in Calgary who works exclusively with traumatized children, and I just can't listen to her anymore because it breaks my heart the way, because they're often from disadvantaged. So it's being old and it's being disadvantaged.
Alain Noël, dans votre présentation, vous avez référé à un peu la justice intergénérationnelle, le fait que déjà on semble dépenser beaucoup pour le secteur des personnes âgées en santé et en pension. So that's another dialogue that we should have at Massey. How do we get there? If indeed there is an intergenerational issue that young people just feel that they are not giving a chance, mais il y a des besoins, but there's lots of needs on the other side. Est-ce que vous avez des solutions?
Bien, il faut comprendre d'abord de ce dont on parle, ce qui n'est pas toujours simple, parce que on dépense beaucoup pour les personnes âgées, pour les soins de santé, les pensions, mais il y a beaucoup de personnes âgées aussi. Et donc, il y en a de plus en plus. Et donc, c'est pas nécessairement inéquitable d'augmenter les dépenses pour les personnes âgées dans une société qui vieillit. Il y a une étude qui a été faite par des collègues suédois qui mesure plutôt la façon dont on remplace le revenu pour les jeunes familles, les gens au travail, les gens passés 65 ans. Les auteurs trouvent que le contrat entre les générations peut être plus ou moins équilibré selon les pays, si on tient compte de ça, non pas de la somme totale des dépenses qu'on consacre, mais la situation qu'on crée pour les personnes qui reçoivent du remplacement. Et la conclusion positive de cette étude, c'est que les États-providence ont été, pendant plusieurs décennies, plutôt pro-old, pro-vieux. Oui. Et dans les deux dernières décennies, on a beaucoup amélioré les dépenses pour les jeunes familles, pour les enfants. Et donc, il y a un rééquilibrage qui s'est fait graduellement. Mais ça demeure que dans une société qui vieillit, on consacre nécessairement beaucoup de ressources aux gens âgés.
If we isolate children from old people, that doesn't help us any. You know, and there was a time, or at least we have an image of a time, how much it really existed, where children knew their grandparents lived near them, their great-grandparents, and you thought old people had value because they did have value. You could see it. So I think that we need to do more work at community level, intergenerational exposure that's meaningful, not just trite, but meaningful.
Well, on this note, I want to thank you. Merci de votre participation. Et puis merci à vous tous d'avoir été ici. Thank you very much. And I think it just shows how important it is to continue to have this dialogue and recognize how even within the university sectors, there are ways in which we need to talk better among ourselves. Les prochains, le 7 décembre, Artificial Intelligence, la créativité à l'ère de l'intelligence artificielle. On March the 7th, we'll talk about lakes and ocean. Those are all our partenariat with the Royal Society. And on May 9th, we'll talk about free expression. Merci beaucoup d'être ici ce soir et merci à nos invités. Thank you very much.